52% are diagnosed at stage 1 and stage 2, which is the early stage of breast cancer. However, we can see here that there is increase in number uh, um, where the patient is diagnosed at late stage, which is stage 3 and stage 4, which as compared to uh, from 2007 to 2011, the number increased in 2012 until 2016. So many people had been diagnosed at the late stage, which is stage 3 and stage 4. And for the risk factor of breast cancer, we can divide it into non-modifiable risk factor and also modifiable risk factor. So for non-modifiable risk factor, the risk increase as age increase. Um, it mainly start after the age of 25 years old and peak at the age of 60 to 64 years old. And although breast cancer can affect both gender, female had much higher risk compared to male to get breast cancer. And for family history, women with family history of breast cancer at, at, at young age have increased risk to develop breast cancer. And also a family history of BRCA1 and BRCA2 carrier. So it will increase the risk for the woman to get breast cancer. And for the reproductive factors, it is related to early menarche, which is less than 12 years old, and also late menopause, which is more than 55 years old. Other than that, the other non-modifiable risk factor is the history of neoplastic disease of the breast. So, if the woman had previous history of breast cancer, she had increased risk to get new primary breast cancer. And if the woman had history of cancer in situ, so she had risk to develop invasive breast cancer. And also, if there is a history of atypical or ductal or lobular atypia hyperplasia, it also will increase the risk for the woman to develop breast cancer. And for the breast density, there is twofold increase in women who had scattered fibroglandular tissue, and fourfold increase in risk in women with extremely breast dense. And the breast density is based on the Birat's composition. Okay, so moving on to the modifiable risk factor, we also have the reproductive factors, and it is mainly related to the use of oral contraceptive factor. I'm sorry, reproductive factor is the nulliparity and lack of breastfeeding. So woman which is nulliparous and lack of breastfeeding, so there is increased risk to get breast cancer, and also late age at first live birth, which is more than 30 years old, will also increase the risk for the woman to get breast CA. And for the hormonal factors, it is associated with the intake of oral contraceptive pills. For the lifestyle, women who is obese or overweight throughout their life had increased risk to get breast cancer, postmenopause breast cancer. And alcohol consumption also increase the risk to get breast CA. And for the radiation exposure, history of radiation exposure mainly at chest area at early age, for example, for Hodgkin's disease, will increase risk for the patient to get breast cancer. Okay. And for the pathophysiology of the breast cancer, it is multifactorial, which involve the interaction between environmental, genetic, and also hormonal changes. So all these factors will cause damage or failure of the repair DNA. So this will lead to the mutation in genome. When there is mutation in genome, it will cause increase in the growth promoting oncogene and decrease the tumor suppressor gene. So this will lead to unregulated cell proliferation. And add on to this, when there's a mutation in genome, there's also alteration in the gene regulating apoptosis. So it will lead to decrease the apoptosis, and add on with the unregulated cell proliferation, there will be colonial expansion. So this eventually will lead to tumor progression and malignant neoplasm. So based on Bailey, it classify benign breast disorder based on the congenital disorder, injury, inflammation or infection. So under congenital disorder, it include the inverted nipple, supernumerary breast or nipples, non-breast disorder including Tietz disease, which is the costochondritis, sebaceous cyst and other skin condition. For the injury, it include fat necrosis and also hematoma. And anti-inflammation or infection, we have ND, which is the aberrations of normal differentiation and involution. And under this, it has cyclical nodularity and mastalgia, cyst, fibroadenoma, duct ectasia, and also periductal mastitis. And for the pregnancy related, we have galactasia and lactating mastitis. So ND is actually the aberration of normal development and evolution of the breast. So we know that breast is a dynamic structure, so it undergo changes throughout woman's reproductive life, and also during the changes during cyclical changes, which is the menstruation cycle. So ND basically consists of four features, which is the cyst formation, fibrosis, and hyperplasia, and also papillomatosis. And usually the clinical features is there are area of lumpiness and also breast pain, which is nostalgia. For the classification of the breast malignancy, we can classify it based on the tissue, which is if it involves ductal carcinoma, or lobular carcinoma. And based on the invasiveness, we have non-invasive carcinoma and also invasive carcinoma, which is the non-invasive, also known as in situ carcinoma, which also further divide into lobular carcinoma and also ductal carcinoma. And based on hormone or gene, we have estrogen receptor positive breast cancer and also HER2 positive breast cancer.
Can I proceed to the presentation? So I proceed to the presentation. So for the first disease I would like to discuss is about Wani, can you next this? For the first disease that I would like to discuss is about fibrocystic changes or fibroadenosis. So it is clinically diagnosed and confirmed by ultrasound. So the mainstay of the treatment is the cyst aspiration, as it gives immediate relief and no further treatment is needed. However, 30% can recur and require the aspiration. Okay. We can reassure the patient after we have excluded the malignancy criteria such as no blood stain and the cysts disappear after the aspiration. So we can reassure the patient that this is not malignancy, but it is only fibrocystic changes. And for the pain management, patient of fibrocystic changes, diagnosis, will present with pain, cyclical pain. So we can give analgesia such as ibuprofen, supportive bra, okay, because it can reduce the edema and reduce the movement of the painful breast. And we also can opt for symptom diary, where we advise the patient, okay, to chart down their pattern of pain throughout the month. So to give an insight what is a true sciatica pain. However, if we fail to reassure the patient, we can give sometimes high dose gamma-linolenic acid, or we call it as oil of evening primrose, and it needs at least 3 months consumption for the treatment to be effective. However, if uh, the the pain is very severe, okay, sometimes we opt for danazole or bromocriptine. Okay, next. Next. Okay, second is fibroadenoma. Fibroadenoma, okay, majority of the patient, okay, regress spontaneously, so no need excisions. Just reassure the patient this is not malignant, and follow up, okay, to see any changes of the size of the lump. However, okay, we can suggest lumpectomy or excisional biopsy if it is enlarged, cosmetic reason, or patient anxiety, patient request, or we suspect malignant features. Rarely we do cryoablation where we freeze and destroy the cell of the fibroadenoma. Okay, next one. Okay, the third one is phyllodes tumor. Okay, bear in mind, fibroadenoma and phyllodes tumor share the same presentation, radiological, and same finding on biopsy. However, the difference are the size of the lump. So, for phyllodes tumor, we will suggest for wide local excision because we can remove also the presence of the cyst in the void. And we can do mastectomy if there is massive tumor, recurrent tumor, or those of malignant type, and KIV for axillary clearance if features suggest malignancy. Next. Okay, for ductal papilloma, okay, the mainstay treatment is the surgical resection of the tumor because it has a higher chance of developing atypical ductal hyperplasia or ductal carcinoma in situ. So, okay, we will do microdocectomy for excision of the affected duct, okay, and which resection if there is a removal group of duct. Okay, next. Okay, is that duct ectasia or periductal mastitis? Uh, okay, for this presentation, okay, duct ectasia actually is not effective. However, it can be overlap with periductal mastitis in terms of clinical features. So, and it also can coexist between duct ectasia and periductal mastitis. Um, for duct ectasia, okay, we know it is non-infective process, but because of the overlap and coexistence of the disease, okay, we can try for antibiotic, which is coamoxiclav, okay, or flucloxacillin and metronidazole. However, okay, if the presentation is more aggressive and recurrent, we can opt for excision of all the major duct under Hatfield's operation. If persistent discharge, okay, we suggest for subtotal or total nipple duct excision. Okay. Next, one. Okay, mastitis and breast abscess. Okay, this is inflammatory, and the most common etiology for mastitis is Staphylococcus aureus. So we will give antibiotics which is flucloxacillin or called amoxicillin. Okay, this antibiotic of choice must be concentrated in milk and can withstand in acidic pH of the milk and do not harm the baby. Okay, for the pain management, we can support the breast by using firm bra on the day and soft bra at the night. Okay, and we can give ibuprofen or local heat to reduce the swelling and emptying of the by continuation of feeding or milk expression. Okay, why it is safe, okay, to breastfeed the infant despite of mother having mastitis. Okay, this is because in the breast milk, it does not only contain Staphylococcus aureus, but it also contain antibody and immunocompetent cell that against the Staphylococcus aureus. So that is why it is safe to continue breastfeed the infant. Okay, for breast abscess, traditionally, okay, we use incisional and drainage. However, this procedure, okay, cause painful wound and then can longer recovery and can cause milk fistula when injured the lactiferous duct. So now, okay, instead of using incisional and drainage, we use ultrasound guided drainage under antibiotic cover, where we allow use solution without the need for incision. Okay, it will have a better result where it has less scarring and then does not general anesthesia, less invasive procedure compared to incision and drainage. And the most important one is it allows continuation of breastfeeding because incision and drainage after post surgery, because of the pain, we do not allow for breastfeeding. Okay, we use the another breast for breast milk. Okay, next.
Okay, can you hear me?
Yes.
Yes.
Okay, for the breast abscess, as long as the skin is intact, you can do aspiration. Okay, but once it's already become, ruptured, okay, so there's no room for aspiration already. So that one you have to do IND, proper IND lah. If not, repeated aspiration can be done. Either guided or non-guided lah.
Okay. Thank you, Miss. Next. Okay, the last one is tuberculosis of breast. This is actually very rare manifestation of TB because primarily it involves the lung. However, we can diagnose by culture or use Zell-Nelson stain. And then for the management, we will give anti-tubercular chemotherapy, which have 6-month regime, 2 months intensive phase with 4 drugs, which is isoniazid, rifampicin, ethambutol, and pyrazinamide, and 2 months of maintenance phase with 2 drugs, isoniazid and rifampicin. Okay, we only do mastectomy only with persistent residual infection. Okay, we suspect this tuberculosis of breast if the patient is have immunocompromised such as HIV infection. Okay, that's all. Thank you.
Okay. And next is triple assessment. Okay, I'll be talking about triple assessment. So triple assessment is a invaluable tool for accurate non-surgical diagnosis of the breast lump, and it allows early and rapid detection of breast cancer. So triple assessment, there are 3 modalities, which are the clinical assessment, radiological imaging, and also biopsy. So for clinical assessment, there are actually 2 parts, which is the history taking and also the physical examination. So for history taking, so first and foremost, we need to know the presenting complaint, right? So in many early breast carcinomas, they are actually asymptomatic. However, and they are discovered during breast screening program. However, large tumors may present as a painless mass. So we need to know more about the painless mass. So we ask about the location and how it was noticed, and we clarify when the breast lump had developed, and then we ask for the size progression, whether it is rapidly increasing in size, because that may be suggestive of breast cancer.
Okay, presenter, no need to talk about history taking and physical examination. That one you already covered during your year 3. Now more of your management.
Okay, okay, next, next. Okay, next. So, next. So now we go for imaging. So imaging, there is mammography and also ultrasound. So there's the main method of radiological assessment of breast is the mammography. So in mammography, there is medial lateral oblique and also craniocaudal view. So for medial lateral oblique, to determine the either upper or lower quadrant, and for craniocaudal view to determine the inner or outer quadrant. So we combine these views to localize the lesion. So, and we report this using BRADS. So the features of malignancy in mammography, there is microcalcification. So 5 or more small lesions of radio-opacities in 1 centimeter area. And there may be architectural distortion and asymmetry in comparison with contralateral breast. And there may be focal mass be seen in the mammography. And for ultrasound,
What else in the mammogram?
what else? Mm,
Speculation.
sorry?
Speculation.
Speculation.
One of the most important
Okay.
features, speculation. And about microcalcification also, it's not only microcalcification, but it is pleomorphic microcalcification. It had a lot of shapes. Okay, satu bentuk macam ni, satu besar sikit, satu besar ni. Okay, pleomorphism. And
Pleomorphic.
it is what we call as clustered. Okay, dia dekat that area saja, dia bukan dispersed, scattered. Kalau scattered tu usually it is a benign. So it is a clustered pleomorphic microcalcification. Okay.
Thank you, Miss. So it's a pleomorphic microcalcification. And for ultrasound, it's more useful in women less than 35 years old, and can be used as the initial imaging modality for less than 35 years. And the features of malignancy in the ultrasound, it can be irregular, ill-defined mass, hypoechoic, and there may be speculations which is needle-like, and there may be increased vascularity using Doppler. And combined mammography and ultrasound improve breast cancer improve breast cancer detection for above 35 years old, 35 years old and above.
Anything else in the ultrasound and mammogram other than the breast?
The lymph nodes.
Lymph node lah.
Okay.
Ini detection of axillary lymph node. Okay, axillary lymph adenopathy. So they have a specific features on towards the lymph node, which is dia macam ni juga features of malignancy for the axillary lymph node, which is rounded. Okay, loss of fatty hilum. Okay, enlarged. All these are features of malignancy. Okay, don't forget about the axilla.
Okay. Thank you, Miss. Next,
What
next.
is sensitivity and specificity?
Specificity is 75%. Okay.
For what?
For the mammogram.
Are you sure 75%? Mammogram is the gold standard tau tak? Takkan 75% je.
Oh, sorry.
You orang ni tak baca ke? CPG tu. CPG tu semua benda ada. Okay, look back cari the sensitivity and specificity of this mammogram, ultrasound, and what happen when there is combined mammogram, ultrasound. Dia mestilah higher sensitivity and specificity, right? So how much it decrease when you do combine imaging? Okay, next.
Okay. Right. So in this picture there is normal. This is the normal mammogram. So you can see the benign lymph nodes and the adipose tissue, and also the ducts and glandular tissue. Next. Next. So you can see that in this part there is focal mass. There is multiple focal mass at the in the mammogram. Next. So on the left picture, there is a speculated mass in the upper breast. So that's might indicate infiltrative intraductal carcinoma. And on the right part, you can see that on the arrow there is tiny sand-like calcifications. So this is also suggestive of intraductal carcinoma. Next. Okay, so this is on identifying just a simple one. So this mammogram to identify breast cancer, it may appear as bright and irregular image with spiky or fuzzy edges. And for ultrasound, it appears darker because it's solid, so it's hypoechoic and may have speculation, so have spikes and also irregular edges. Next. So this is the BRADS. BRADS is breast imaging reporting and data system. So it's designed to standardize the breast imaging reporting so that uh, we can assess the patient for management. So in category 0 is needs additional imaging or prior examination. So we need to recall for additional imaging or await prior examinations. And for number 1, when the patient is negative for breast cancer, so we need to have routine screening, and also for benign, the same routine screening. For category 3, it's probably benign, so have to have short interval follow up for 6 months or continued surveillance. And when the category is 4, it's suspicious, so you have to have start with the tissue diagnosis. So we need to have biopsy, core biopsy. And it's the same for number 5, which is highly suggestive of malignancy. And 6 is non-biopsy, so it's proven, so we need to have surgical excision when it's clinically appropriate. Next. So now we go to the last part, which is biopsy.
Other than those mammogram and ultrasound, what else the imaging in the breast?
Imaging of the breast. Magnetic resonance imaging.
So why don't you talk about MRI?
Because it's only considered when there is invasive lobular cancer.
Not necessarily.
It can be
Okay, the standard screening tool for breast cancer is mammogram and MRI, not ultrasound.
okay.
Ultrasound ni complementary sahaja. So it is not a good screening tool. That's why you have MRI. But in a hospital setting, you don't do MRI that frequent because MRI is not widely available, costly and also lama. Okay, the procedure also takes time. Okay, that's why people do ultrasound for a younger patient because of this limitation lah. But the gold standard is not ultrasound, but
Yes.
MRI. Okay, that is the role for the screening. Other than that, MRI also important in terms of yang you cakap tadi lah, lobular carcinoma, okay, genetic breast cancer. So all these things are need to be mentioned lah. MRI ni very important.
Okay.
Baca CPG tu. Okay.
Okay. So in biopsy, so there's core needle biopsy provides full histology as opposed to fine needle aspiration, which only provides cytology. So it's become a well-established tool for diagnosing both palpable and non-palpable breast lesions. So when there's no core needle biopsy available, then you consider to use FNAC for pathological assessment of palpable breast lumps. Okay. Next. So you can see fine needle aspiration, it only collects sample of cells. It only looks at the specific cells. As for core needle, we can see the differentiation between invasive and in situ carcinoma. Next.
Okay, for the FNACs, you can do as a blind technique or guided biopsy. What do
Yes.
you mean guided biopsy? Either ultrasound, mammogram, or MRI.
Okay.
Both. Fine needle aspiration FNAC ke, true cut biopsy ke, or can be done guided biopsy.
Yes. Right. Thank you. Next. So this is this is actually the summary. So for FNEC, you can get the diagnosis, but only when the core biopsy is not available. However, you cannot both FNAC and core biopsy cannot get estrogen, progesterone, and HER2 receptor status. And for stereotactic biopsy, it's basically done under mammography guidance. So it's actually a subset of core biopsy. So if confirmed, you use hook wire wide local excision. And for ultrasound guided biopsy, it's a subset of core biopsy done under ultrasound. And it's the same thing. If confirmed, proceed with hook wire wide local excision. And for excisional biopsy, so it's only for small breast lesion. So you remove when using excisional biopsy. When do excisional biopsy, it removes the entire lump. And last is the wedge biopsy is for inflammatory breast cancer, fungating breast cancer, and ulcerative.
Of size of the lesion, which one you do FNAC, which one you do true cut?
For I'm not sure, miss.
So okay, FNAC only get cytology. Usually, meaning it use a small needle. True cut biopsy. So in true cut biopsy, of course, you need to have a bigger lesion. What do you mean by bigger lesion? Usually 3 centimeter and above. Okay. For FNAC, usually 2 centimeter and below lah, because it is small. Okay.
Okay.
Okay. For the patient with this one, another one that you mentioned, use one waist biopsy. Okay. What do you mean by waist biopsy? You take the tissue at the edge of the tumor. Okay, age. Sebab fungating ulcerated mass ni dekat tengah-tengah ni all are necrotic tissue. So you can take biopsy from that area. Okay. Nanti you akan dapat negative for tumor lah. So you take at the periphery. Okay, about 1 centimeter of tissue. Okay.
Okay, thank you. I think that's all. Next. Okay, that's all that.
So thank you so much, Is, and also Miss. So I will continue the management of the breast cancer. So before that, Assalamualaikum warahmatullahi wabarakatuh. So my name is Muhammad Arim Takim. So next, so the first principal management of the breast cancer or any other cancer is staging, which you are familiar with the T and M staging, tumor, nodes, and metastasize. So next. So let's start with T, which is a tumor. So tumor T, there are four, which is T1, T2, 3T, and T3 and T4. Next. So T1, there are three types, T1A, next, T1B, and T1C. So for the T1A, is from 0.1 to 0.5 centimeter. You have to remember this. So T1B,
Okay.
0.5 to 1.
Staging, you don't have to remember about this ABC, T1, ABC, no. You just need to know T1, T2,
T1.
T3, T4, ABC. Okay,
Okay.
just noted. Okay, first in terms of size, kan, T ni because of the tumor size. But if you look at the T4, okay, ABCD, it is not about size
Yeah,
anymore.
it's not about size.
Okay,
Yes.
it's about the extension of the tumor. Okay, this one you must always be a bit detailed here in terms of 4A extension to the chest wall. So what do you mean by chest wall? Chest wall ni not only pectoris muscle is not considered a chest wall. Okay, invasion to the chest wall means at the intercostal muscle to the rib. Okay, okay, pectoris muscle is not T4A.
Okay.
Okay, ni you ambil kat mana TNF staging ni?
Dekat internet.
Yelah, internet pun memanglah internet. Where is the source of staging?
American apa tak ada GCC.
Are you sure? Macam salah je ni. This is not correct.
Sebab dekat dalam CPG tak ada. So sebab
Dalam CPG tak ada. Are you sure dalam CPG tak ada? You dah tengok ke CPG dekat belakang-belakang tu? Mesti ada TNM staging. Benda wajib ni. Kau nak menipu ya. Cari.
Jap. Ya betul lah. Ni daripada CPG lah tu. Miss.
Ni daripada CPG.
Ya,
Masalah
CPG and the latest 2019.
colour macam lain je ni. Colour yang ni eh. Let me see.
Bulan-bulan.
Okay. 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 If you read this one T4A, okay. Okay. Invasion or adherence to the pectoris muscle in the absence of invasion of the chest wall, structure does not qualify as T4. Understand or not? Okay, maksudnya although there is invasion to the pectoris muscle, but if it is pectoris muscle alone, it does not consider as T4. Okay, it must go beyond that, which is the chest wall. Faham? Okay, so pectoris muscle alone does not qualify as T4. Okay, so T4B, what do you mean by T4B? To the skin. Okay, what do you mean by the skin? Okay, ulceration, satellite nodule, okay, poderons, okay, all these things kalau they just attachment to the skin, for example macam you nampak dimpling ke, lettering ke, that still not T4B. Okay, that one is because of some fibrous the ligament, because the tumor already invade the ligament, so when you move the tumor, so it become dimpling. Okay, so that one is not considered as T4B. Okay, so C both lah. Okay, D inflammatory. Inflammatory breast cancer has a specific criteria, specific diagnosis. That one you must go back to the criteria for inflammatory breast cancer. Okay? Okay, next.
So okay, so this Miss already explained. Next. So these are the example, which is Miss explained for. T4A extension to the chest wall, not only to the pectoral muscle. Okay. For T4B extension to the skin, it can present with satellite nodules and also purely orange. And T4C, the combination of T4A and T4B. The next. Okay. So for the nodules, nodules, there is an N1, N2, and N3. So N1, it is a
Okay.
movable lateral.
Okay, if you look at this TNM staging, dia ada dua, clinical and pathological, right? So what you're talking now is about the clinical
Clinical.
staging. Okay, meaning prior to HPE lah. Okay, when you see patient in ward, so you going to make a clinical staging. Okay, so TNM staging ni tak banyak benda yang nak kena ingat. All this ABC ni you tak payah tahu kecuali yang T4 only. Yang lain tu tak payah. Okay, this one N0, N1, N2, N3 enough for you all.
Okay.
Okay, N1, N2, N3, that's all. So you baca yang dekat N1 saja, you tak payah baca anak-anak ada tu semua. Okay, so N1, it's always remember, ipsilateral mobile.
Mobile.
Okay, ipsilateral mobile, axillary lymph node. Okay, N2, when it's already fixed method, okay, or it already goes to the internal memory nodes, okay, it's already considered as N2. Okay, so N3, okay, infraclavicular internal memory, supraclavicular nodes. Okay, this one is considered N3 already. So usually yang you dapat palpate is actually the supraclavicular. Infraclavicular, very rarely you can get nodes. Usually by imaging, yes. Okay, a bit difficult. So you tahu yang ni je lah. Okay. Okay.
Okay.
Okay, next.
Next. So this is the picture. Okay. Next. Next. Okay. So we go to the metastasize M. So M1 there is only two, M0 and also M1. So M0 there is no clinical or radiographic evidence of metastasize. However, for M1 there is a clinical and radiographic evidence of metastasize. And also we can do a histological proven. And the metastasize is larger than 0.2 mm. Okay, next. So this is the stage of the TNM. So you can read it because it is very long for me to explain. So for summary, there is five types of stage, which is stage 0, stage 1, stage 2, stage 3, and stage 4. So in CPG, next, they are further classified by early breast cancer and stage 2, next. And stage 3 is called local advanced breast cancer. And stage 4 is advanced breast cancer. Okay, next. So for the spread, as I mentioned before, there is a local spread at the skin, at the subcutaneous tissue and the chest wall, which is T4. And for the spread for the lymphatic, it can spread to the axillary, internal mammary lymph node, and also supraclavicular lymph nodes, which is N. And hematogenous, it can spread to the lung, to the liver, to the brain, adrenal, and ovary, which are considered as metastasized. So next. So
So
these
where
are
is
the summary.
the commonest site of metastasis?
So the commonest site of the metastasis is to the chest wall, to the axillary, and also to the lung and
That
bones.
one girl, distant metastasis kat mana? Where is the commonest metastasis? Local.
To the lung and bones.
Which one? Commonest.
Uh, the commonest to the lung. To the bone,
Lung
to
ke?
the bone, yes. To the bone. Sorry, Dr. Sorry, Miss.
Okay.
Okay. Okay. The commonest one to the. Okay, so this is the summary. You can read it.
Okay. The commonest site of metastasis is axillary lymph node
Okay.
before it goes somewhere else, which is the bone. Okay. Okay, next. Seventh edition. Now it's already 8th edition, right?
Edition, right? Yes.
Ini tak payah lah. This is the
Yeah.
7th
19.
edition.
Okay. So next. So for staging, we have to do baseline imaging, such as if the patient for the early, if the patient asymptomatic, we have to do chest X-ray and also ultrasound of the abdomen. If the patient present with symptoms such as bone pain and jaundice, we must consider as there is a metastasis. So we have to do chest X-ray, ultrasound, and also CT TAP, CT thorax abdomen pelvis, and bone scan. For local advance, which is stage 3, we must do the CT TAP because we want to know whether there is an extension or there is a presence of metastasis. And also we do the bone scan. For the advance, so we do CT TAP to confirm the extension or the presence of metastasis. If there is a suspicious, so we can do PET scan. And then also do bone scan. Next. Next. Oh, okay. So this is a brief review of the treatment of the breast cancer. After this, Farisha will explain the more detail of the breast cancer. So as for the early, we can do with axillary lymph node drainage and also radiotherapy. However, mastectomy and also axillary lymph node drainage are considered. After that, we chemotherapy have been done, and if there is an estrogen receptor positive, it is considered to do hormonal therapy, which is tamoxifen. So for the local advance, if the tumor is cannot be resectable due to the size, so we have to give neoadjuvant chemotherapy to decrease the size of the tumor. And then BCS, which is breast conservative surgery, and also AIND, radiotherapy, can be done. However, mastectomy and AIND are more preferable. And then chemotherapy and hormone therapy also can be done. For the advance, it is a palliative care, such as we do palliative chemotherapy and also radiotherapy, palliative mastectomy with or without AIND. And also this palliative care is to maximize the quality of life and also to reduce the symptoms such as bone pain and also jaundice. So we can treat, we can give hormone endocrine treatment or
Mana ada dekat buku endocrine treatment.
yeah. Oh, tak ada. Because
Radioterapi. Ya.
okay, radiotherapy lah, radiotherapy. Okay.
Okay, and then what do you mean by advanced is already metastasis. Okay, so what do you mean by metastasis? So you tengoklah where is this metastasis. Let's say patient had a bone pain because of bone metastasis. So your management should be painkiller lah nombor satu dulu.
Painkiller.
Okay, treat the pain. So you give lah all painkiller based on the WHO step ladder. Okay, and then you can give radiotherapy to the affected bone. Tapi tengoklah bone tu dekat mana. Kalau dekat spine, semua dia orang boleh bagilah. Okay. Okay, lagi in terms of metastatic, okay, patient ada ulcerated breast lesion. So your management should be what? Dressing.
Yes. Dressing.
Okay, dressing. Sometimes dia ada bleeding over the lesion kan. So you kena tengoklah. So kalau HB low, you top up lah HB. And all this advanced disease ni associated dengan malnourished. Okay, patient tak lalu makan, isn't it? Patient cachexia. So what you need to do is nutrition support lah.
Yes.
Okay, bagilah all the susu-susu yang ada. Okay, nutrient fiber ke, pectamen ke, depends on the patient itself. Okay, individual patient yang jenis macam mana. Albumin low ke, you bagilah pectamen. Kalau patient yang jenis diabetik juga, you bagi nutrient diabetik. Okay, all these things must be addressed in a palliative care. Okay, palliative care. So kalau patient yang ada liver metastasis kan, patient jaundice. Okay, when patient had liver metastasis is very difficult sikit because this is a not a good prognosis. The metastasis compared to bone. Kalau bone ni patient still can ambulate, nutrition wise pun still okay compared to kalau yang ada liver metastasis, lung metastasis. Okay. Okay. Contohnya patient lung metastasis, right? Shortness of breath, right? Because of fluid effusion. So management is what? Oxygen therapy, fluid tapping, okay, chest tube ke. So depends lah. Okay. Lagi talk about bone mass again. They can have like hypercalcemia. Okay, another issue is hypercalcemia, which is quite common. So this kind of patient, you need to give a lot of fluid to reduce the calcium. And then you boleh bagi a lot more macam biphosphonate, isn't it? Kalau you jumpa patient like you can give biphosphonate, zometa lah. Basically all these things are to reduce the calcium level. And sometimes patient also can come with lower limb weakness. Okay, cauda equina syndrome because all this spine fracture, compression. Okay. And then they can also, we can refer to orthopedic. They can do some instrumentation. Okay, in a good, in a fit patient lah, in a fit patient. Okay, so for early ke, locally advanced ke, sekejap. Next slide dulu. Tengok apa you have.
Tak ada.
Tak ada dah?
That's all.
Ada lagi orang present?
Ada lagi depan.
Okay, lepas ni present apa pula? Tengok dulu.
Pasal molecule about the management.
So tak ada dah, pasal surgery semua tak ada dah?
Ada lepas ni.
Ada lepas ni.
Proceed dulu tengok.
Okay, Bismillahirrahmanirrahim. Everyone can hear my voice clearly. Okay, can you see my slide? Hello?
Yes.
Alright. So, Bismillahirrahmanirrahim. My name is Annie Farisha and I'm going to talk about the management of breast carcinoma. Okay, so the principle of management for breast carcinoma is the first is to establish the diagnosis. The second one is to control disease in affected breast and chest wall. And the third one is to prevent and treat local and regional disease in early breast cancer. And the fourth one is to control advanced and disseminated disease. So in
management of breast cancer, we have divided it into two, which is local regional control and also adjuvant systemic treatment. For the local regional control, we have four types of surgery, which is breast conserving surgery, mastectomy, reconstructive surgery, and also axillary surgery. And the next one, I will be talking about the adjuvant systemic treatment, which comprises of three things, which is chemotherapy, endocrine or hormonal, and targeted, which is the biological therapy. So the first one is the breast conserving surgery or white local excision. What is BCS? It is how we remove tumor with grossly 1 cm margin and followed by radiotherapy.
Surgery, not what local excision, but what local excision plus axillary clearance. Okay, when you talk about breast cancer, don't forget about axillary clearance. Okay.
I will be explaining about the axillary clearance after this. Okay, so what do is that we aim to remove the tumor with 1 cm microscopic margin of normal breast tissue. But if the tumor is impalpable, we do the excision by ultrasound guided or hook wire under mammography. So BCS is usually for patient for a better body image
Okay,
and sexual
ultrasound guide,
function.
wire under mammogram, which one ni?
Uh,
What do you mean by
hook,
this statement? Slide lagi satu.
hook,
Previous slide.
this one.
Palpable tumor, excision by ultrasound guided or hook wire under mammogram.
Uh, both of these are for the impalpable tumor.
Yelah, what do you mean by that?
Uh,
Ultrasound
means that
buat excision and then you buat excision.
yes.
No. Okay, when you write something, make sure you understand what it is. Okay. So when you talk about non-palpable tumor, okay, before this you already had this triple assessment semua tu. So in a impalpable tumor, of course your triple assessment going to be what? Ultrasound guided FNEC. Or
Yes.
ultrasound guided biopsy lah, mana-mana lah. Okay, because it is impalpable. So when you confirm that patient had tumor, but it is non-palpable, so what you can do is hook wire localization. Okay, usually the radiology will do this hook wire at the radiology department under ultrasound guided. Okay, so dia buat ultrasound ke mammogram ke, usually ultrasound lah. Ultrasound, detect where is the lesion, put a wire there. And then this patient will be pushed to OT for surgery. What local excision? With hook wire kat situ. Okay. So the macroscopic margin is about 1 cm from the tumor. Okay.
Alright.
Okay. So this hook wire ke patient palpable ke non-palpable ke still 1 cm margin.
Alright.
Okay.
Okay, thank you, Miss. So for the selection criteria for BCS is the first one is the single lesion clinically and mammographically. A tumor that is not larger than 3 cm and there is no extensive in situ component. And then the tumor are more than 2 cm away from the nipple areola complex. And then the lesion of lower histological grade and also it must have not have extensive nodal involvement.
The thing that we do, okay, basically for the breast conserving surgery, as long as you can, you can provide a good prognosis, it doesn't matter about the size that much. Because it depends on the breast size. Kalau breast kecil kan, let's say cut A, dia punya tumor about 4 cm, difficult for you to do breast conserving surgery. But if the tumor is 4 cm, but the patient had cut B, breast, you can do BCS. Okay? So it depends on how much you can take and how much is the breast tissue left. So as long as you did not take more than 20% of the breast tissue compared to the whole breast, you still can do breast conserving surgery. And sometimes also the location also take an account because when the tumor is at the retroareola, okay, at the retroareola area ni, there is the largest, apa tu, the largest breast tissue situated at. Okay. When you want to talk about this thing, kan, you need to know how this local excision being done. Okay, of course you take 1 cm tumor, 1 cm margin from the tumor, but the deep margin, maksudnya bila you nak potong tu, superior, atas bawah kiri kanan 1 cm, but when you talk about to the chest wall, it must go to the chest wall. Maksudnya, chest wall pula dah, to the pectoralis muscle lah. So, you akan potong dalam sampai you jumpa muscle. So, tak kira lah. The tumor ni, how not necessarily 1 cm margin. Sometimes can be 4-5 cm from the tumor to the chest wall. Okay. So when you talk about the retroareola tumor, so you need to take the tissue until betul-betul kena dekat pectoralis and also chest wall. Okay, so kalau kat situ you already remove a lot of breast tissue, so you cannot save you cannot serve the purpose of cosmesis anymore. Okay, so about histological grade ni pun sama, because sometimes okay, because BCS ni you can in let's say in a grade 3 tumor pun you still can do, as long as the patient follow the treatment plan, which is after breast conserving surgery, the patient need for radiotherapy, chemotherapy, apa semua tu, must follow all these things. Okay, but must be bear in mind, you kena explain kat patient, selagi the breast is there, the risk of recurrence still there. Okay.
Alright, thank you,
Okay.
Miss. After this, I will edit the slide, which is the tumor mass less than 20% of the breast tissue.
Bukan the tumor less than 20%. You kena remove less than 20%. So including
okay. Including the 1 cm margin. Okay.
Yeah.
Sorry. Okay. Alright, that's good. Alright, Miss, thank you. Okay, so for the next is mastectomy, which we all know removal of the whole breast. So mastectomy. Okay. So mastectomy. The first, I think my voice is.
Nobody do radical mastectomy anymore, and the gold standard is modified radical mastectomy. So kita tak payah sebut pasal this radical mastectomy. Okay, it is a
Nowadays we do simple kan ni?
Apa dia?
Nowadays we do the simple mastectomy, right?
Hey, we do modified radical mastectomy lah, the gold standard.
Oh, because I read in the book they said that this one is the modern technique.
Buku mana tu? It is a modified radical mastectomy. This is the gold standard. What is the difference between these two, MRM plus simple mastectomy? Because modified radical mastectomy is actually mastectomy axillary clearance. Okay, plus axillary clearance. Simple mastectomy ni, you just remove the breast only.
Breast, okay.
You did not do any axillary surgery. And simple mastectomy ni usually for what? Palliative. Okay, palliative care, or in case of patient yang dah buat BCS, kan dia dah buat BCS, lepas tu develop recurrent over that breast. Okay, you tak boleh dah nak bagi kat patient tu. Okay, because nanti you nak kena bagi radioterapi lagi. Patient yang dah buat BCS sebelum ni, the patient already had radiotherapy done over that breast. You cannot give another radiotherapy to the same breast. Okay, so the option you have is simple mastectomy.
Okay.
Okay. So
Right.
perfect radical mastectomy is remove the whole breast tissue plus axillary clearance.
Okay.
Okay, next.
Right. So the next is breast reconstruction surgery. So breast reconstruction surgery usually we offer to patient with post mastectomy, and if patient need radiotherapy, breast reconstruction surgery usually will be delayed because the wound healing problem will delay the radiotherapy. And also radiotherapy can cause contracture and unacceptable results. So if the patient need radiotherapy, we have to delay it first. So the option for the BRS is two, which is implant plus tissue expander, or the tissue transfer technique. The implant and tissue expander is a quick operation, no donor site mobility, but it is difficult to recreate a larger breast. But for a tissue transfer technique, it is will result in the patient to have a more natural feeling. But however, it is a longer operation and have a donor site mobility and need additional procedure to augment reduce contralateral breast and new nipple. So usually we took it from the transverse ductus abdominis or deep inferior epigastric perforator or the latissimus dorsi. Okay, so the aim is to restore natural breast shape, reestablish its symmetry, and also to create a nipple areolar complex. Okay, so the next one is axillary surgery. So we have two types, which is the axillary node clearance or the sentinel nodes biopsy. So this is one of the algorithm for early breast cancer that I took from CPG to addition. So for the axillary part of the surgery, if the clinical lymph node is positive, we straight away do the axillary clearance. But if the clinical lymph node is negative, we do the sentinel lymph node biopsy first. And then if it's positive, which is more than two of the nodes is positive, we straight away do the axillary clearance. But if it's less than, if it's two or less, it depends on the surgery.
Sir,
If
what
it's
do you mean by
BCS,
clinical lymph node negative?
means from the physical examination.
Not only physical examination but also imaging.
Okay.
Okay, let's say you palpate, you can't feel the lymph node, but when you do ultrasound mammogram, they say there is enlarged lymph node. Okay, so in that
Okay.
case, you can't do sentinel lymph node biopsy anymore. Okay, it's already considered clinical lymph node positive. Okay, so
Right.
in this clinical lymph node ni maksudnya based on physical examination and also imaging. Okay, nodes negative, then we proceed with sentinel lymph node biopsy. Okay, this one in an early breast cancer, which means in a stage 1 and stage 2 disease, which is N0 N0 belaka lah. Okay, N0 N0 at that time. Okay, you see axillary surgery you ada tiga kat situ kan. Axillary lymph node sample, nak pakai sample lah. Either it's axillary sampling, axillary clearance or sentinel lymph node biopsy. But people do not do axillary sampling anymore. Okay, we do axillary clearance and or sentinel lymph node biopsy. Okay, axillary clearance means up to level 2. Level 2. Okay, behind the pec minor. Okay, next.
Alright. So the principle behind the sentinel lymph node biopsy is that the lymphatic spread of the tumor usually always follows the predictable pattern. With a sentinel node is the first to be affected. So how to identify is that first we identify by using isotope bound to albumin, and then we inject it to the
Okay,
tumor.
no need for you to know details about the sentinel lymph node biopsy.
Okay.
You all tak sempat dia sampai kat sini.
Okay. So tak apalah. Okay. I will go straight away for radiotherapy. So radiotherapy is a whole breast radiotherapy consists of 45 to 50 gray dose of radiotherapy applied to the whole breast with an optional 10 to 15 gray boost to the tumor breadth. And radiotherapy, it should be offered to the following post-mastectomy breast cancer with one or more positive lymph node or with positive margin not amenable for surgery. And should be considered in node negative T3 or T4 breast cancer. In post-BCS, all patients should be offered with radiotherapy, just like what Ms. said before. And after this, we will go through one by one the algorithm for early, locally advanced, and also advanced breast cancer. So benefit for radiotherapy is to improve local regional control, it reduces tumor recurrence, and also reduce mortality from distant metastasis. Okay. So so usually we do this over 3 to 5 weeks, and these are the common complications for radiotherapy, which is fatigue, skin irritation, breast pain or swelling. The late complication for radiotherapy, which is persistent breast edema, pain fibrosis, and also skin hyperpigmentation. However, there is a late complication that can cause to the patient, which is the rib fracture or permanent fibrosis, or also the radiation-induced sarcoma. And important side effects is that radiotherapy can increase risk of arm lymphedema. Okay, so we move on to the adjuvant systemic treatment. The first one is the chemotherapy. So chemotherapy, it used to eradicate distant micrometastasis and also to improve survival. So the regimen is, as you can see, CMF and FEC. But nowadays we use this one, FEC, which consists of 5-fluorouracil, epirubicin, cyclophosphamide for 3 cycle, and then we plus the taxane for 3 cycle. And usually this one is the commonest regimen now. And the indication, I think you can read it by yourself. And the short-term toxicity for chemotherapy is that this patient can cause, of course, nausea, vomiting, alopecia, mucositis, and also neutropenia. The long-term complication would be the premature ovarian failure and also early menopause. And actually, taxane is the newer class of agent that can promote the microtubule polymerization that can lead to cell death. So this is one of the best chemotherapy agent that we can give.
Okay, for this chemotherapy, you don't have to know about the regime. Okay, but you must know about the side effects. Okay, yang you mentioned tu lah, nausea, vomiting, alopecia, and important to know about neutropenic sepsis. Okay, neutropenic sepsis. Okay, because patient come quite frequent because of this neutropenia. Okay, if you see from the types of chemotherapy, right, FEC and taxane, usually taxane would cause more of neutropenic sepsis compared to FEC regime. Okay. Okay, so neutropenic because when you plug patient that already has or already known to have breast cancer, you must always ask about, okay, patient dah buat chemo berapa kali, masa buat chemo ada apa masalah. Okay, during chemotherapy, because of neutropenia and also anemia. Okay, because they can cause bone marrow suppression. Kan, bone marrow suppression. So, what is cell low, HB low. So, you kena tanya history of blood transfusion, okay, history of admission because of neutropenia. Okay, this is our important history. Okay, while you're taking proper history taking. Okay, next.
All right, so the next one is the endocrine therapy. Endocrine therapy is a current option for adjuvant hormone receptor positive breast cancer. So the ER and PR positive patient lah. And then we can offer for tamoxifen for 5 years, or aromatase inhibitor alone for 5 years, or sequential treatment with tamoxifen and aromatase inhibitor for 5 years, or tamoxifen tamoxifen up to 10 years, or tamoxifen followed by extended aromatase inhibitor for 10 years. So usually the tamoxifen is actually the selective estrogen receptor modulator for ER positive patient. And AI is actually the aromatase inhibitor, which usually we give to the commonly used to the postmenopausal breast cancer patient. However, aromatase inhibitor can have a side effect, which it will associated with a risk of fracture due to bone loss. So can you imagine patient ada breast cancer, lepas tu ada meds, and then dia pakai lagi aromatase inhibitor. So that's why in CPG, it recommend that all breast cancer patient who are in aromatase inhibitor should have bone densitometry, which is the DEXA scan, done at baseline and periodically thereafter. So that's why we give the biphosphonate or denosumab if the T-score is less than negative 2.0 in DEXA X-ray. Okay, because the risk factor of osteoporosis lah. And then the side effect for tamoxifen is the risk for endometrial hyperplasia and carcinoma. Okay, so the next one is the biological therapy or the targeted therapy, which is the HER2 therapy. This is for patients with HER2 positive lah. And then we use trastuzumab, which or the trade name is the Herceptin. So human epidermal growth factor receptor HER2 test.
When do you start this HER2 therapy? Okay, that's why you need histopathology report. Okay, when you already operate the patient, okay, you send the mastectomy specimen ke, what local specimen ke, okay, so they will do this hormonal test, hormonal status and also HER2 status. Okay, so when ERPR positive, you can give hormonal therapy, which is tamoxifen ke aromatase inhibitor, or when there is HER2 positive, okay, in which you need to proceed, tak apa, you tak payah tanya tu. When there is HER2 positive, you can give trastuzumab, okay, or Herceptin. Although HER2 positive is a poor prognostic factor, it has medication. Okay, HER2 is not a good marker. Okay, ERPR positif bagus. HER2 positif bad. Okay, but you have something that you can give. Okay, next.
So as a continuation from what Miss has said, usually we get the result from the pathologist about the HER2 receptor. If the result is 0 or 1 plus, it means that it is HER2 negative. If it's 2 plus, it is equivocal. So that's why for equivocal in situ hybridization test to confirm if the patient have a HER2 positive or not. And of course, if 3 plus positive, the trastuzumab, which is the Herceptin, should be given to a woman with HER2 positive breast cancer. Alright, so this trastuzumab usually we give for 6 months in adjuvant settings and may be considered based on the discretion of the treating clinician. So other than IV, we can also give subcutaneous, which is an alternative. Right. Okay, so let's go through the algorithm quickly, one by one. The first one is the early breast cancer. Okay, so reduce the tumor. And then about the surgery.
Okay. Now, if you T2 is also considered early breast cancer, right? Okay, so T2 ni up to 5 cm. Okay, 5 cm. In what case you give neoadjuvant systemic therapy in case of you want to do breast conserving surgery lah biasanya. Okay, so you bagi uh, 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 apa tu chemotherapy first to shrink the tumor so that it is amenable for breast conserving surgery. Okay, but most of early breast cancer you can proceed with surgery straight away without neoadjuvant systemic therapy. Okay.
So in CPG, it says that usually the neoadjuvant systemic therapy we give for are indicated for the triple negative disease lah, which is the negative for ER, PR, and HER2.
Okay, algorithm ni kan early breast cancer ke apa tu early breast cancer ke locally advanced ke as long as the tumor is operable when you see the patient you can proceed with surgery. What do you mean by operable and non-operable? Non-operable ni maksudnya when you see the affected breast, you need to know whether you can you can close the chest wall or not after you remove the tumor or the breast. Okay, so let's say in terms of locally advanced, there is already skin involvement. For example, Poderons. Poderons ni you kena must be very careful sebab dia punya area tu can be big or can be small. Okay, because you need to get a good margin. So, when you want to cut the breast, you kena ambil sekali dengan skin. Okay, skin. Sekali dengan nipple areola complex. So, you must take all these Poderons punya skin juga. You tak boleh tinggal because that is all are tumor. Okay, so bila you nak close, when this one a bit technical lah, nak cakap kat korang ni. Okay, bila you remove the breast, okay, you must have a skin cover. So kalau before surgery, you can't do that. You kena bagi neoadjuvant therapy. Meaning neoadjuvant chemotherapy. Okay, so that you can shrink this tumor, this Poderons ni boleh hilang. So that barulah you remove and close the chest wall. Okay. If the tumor is operable, you can go for surgery and then proceed lah with the chemo ke radiotherapy ke or anything after that. Okay, tak payah tahu banyak-banyak sangat pasal all this technical management ni. You dah boleh sebut mastectomy, breast conserving surgery, axillary clearance, chemoterapi, radioterapi, targeted therapy, ataupun endocrine therapy sikit-sikit tu dah kira bagus dah tu. Okay, all these things are more to expose that. Okay, untuk tahu peduli management ni. Okay, okay, next.
So for locally advanced breast cancer, we divide it for if the tumor is operable or inoperable. So of course for
I dah beritahu dah tu.
okay.
Ada lagi?
Untuk metastatic. Metastatic.
Okay, metastatic. Okay, metastatic breast cancer ni, what is more important is palliative. Because here, when you diagnose patient has metastatic breast cancer, your aim of treatment is no more curative. It's already become palliative. So kalau palliative ni macam yang tadi lah yang saya cakap. Okay, you need to deal with the symptom of the patient kan. Ulcerated breast ke, pain ke, bleeding ke. So you must address all the issue and then address the nutritional status of the patient. Okay, and then all the complication that occur because of the metastasis. Kan macam hypocalcemia ke, jaundice, pleural effusion, all those things. And also, okay, for the surgery, what you can do is, you can do simple mastectomy or you call as toilet mastectomy. Toilet mastectomy ni maksudnya you just remove the tumor, the affected tumor only. Okay. Contohnya patient datang dengan fungating breast cancer. Okay. So the purpose of treatment ni, you just nak bagi improve quality of life. So that patient tak adalah dengan berbau busuknya, dengan bleedingnya, isn't it? So you just remove the area and then cover the chest. That's all. You don't talk about margin-margin semua ni, tak ada. Okay, you don't talk about all those things. You just nak relieve the symptoms only. Okay. So palliative care not only to the patient but also to the family members must be involved lah. Okay, so lagi anything, any other things?
Itulah rasanya doktor dah cakap semua dah. It depends on the patient punya status jugalah pasal dia kan sisik breast cancer ni. So I think the thing that are important is that if the patient with ER or PR positive, we give the hormone therapy. If the patient with HER2 positive, we give the Herceptin with the chemotherapy. And if it's negative, we just proceed with chemotherapy.
So in a
That's all with adjunct biphosphonate.
Okay, in a metastatic breast cancer, you don't call a neoadjuvant ke adjuvant chemo no more. You call it as palliative chemotherapy.
Okay.
Okay, palliative chemotherapy. You can give adjuvant endocrine therapy, tak ada masalah. Even radiotherapy also can. Palliative radiotherapy. But the aim of treatment is just to, for example, bleeding, right? You want to just stop the bleeding. So you can give palliative radiotherapy. You want patient datang dengan fungating breast lesion, you bagi palliative chemotherapy so that dia boleh shrink and tak ada dah all this ulcer. Tapi the tumor is still there. Okay, any question?
That's all for me. So these are my reference.
Okay, no more question Okay, that's all lah. Thank you very much. Nanti presenter bagi nama siapa yang present tu, I need to give marks to you all. To the presenter lah. Okay. Okay, Assalamualaikum.